Hey everybody, Dr. Avizo here. In this video, we're going to talk a little bit about ventricular arrhythmias, pre-excitation syndromes. We'll talk a little bit about SVT to start things off. And I feel like this video is kind of that last step, that last push when we're talking about, electrical conductive physiology and everything that we've kind of hit on so far. So this is a pretty big video. So let's once again just jump right in. So we talked a lot about atrial arrhythmias. We talked about atrial fibrillation, we talked about atrial flutter, but what about supraventricular tachycardia? Now this really isn't a ventricular tachycardia, it's a supraventricular tachycardia, meaning it usually arises above the ventricle somewhere. So typically either somewhere in the atria or in the AV node. So when you're thinking about supraventricular tachycardia, we're really talking about three major categories. We're talking about atrioventricular re-entry tachycardia, atrioventricular nodal re-entry tachycardia, and atrial tachycardia. So I know this can get really confusing, and for step one, the nice thing is you don't really have to know a ton about this stuff. As you go on in your medical career, you'll kind of learn a little bit more, but I'm at least going to introduce you to this and then the high yield things that you should remember. But the first thing is, before we go any farther, how do you differentiate SVT, the supraventricular tachycardia, from a sinus tachycardia? So, you'll hear some people say if the heart rate's greater than 150, then it must be SVT, right? And if it's less than 150, it must be sinus tach. And the reality is that's just not true. For example, if you go and you jump on a treadmill and you start sprinting, right, you can get your heart rate over 150. That doesn't necessarily mean that you're in supraventricular tachycardia. It doesn't mean that you have a reentrant pathway going on. Okay, so the thing is, sinus tach isn't defined by the speed limits of a heart rate. We already know, the max heart rate is 220 minus your age. So you can have sinus tachycardia really at any point in this range, right? Because that's going to be the max heart rate. That's something that we already talked about. In reality, sinus tachycardia is different from supraventricular tachycardia based on how long it typically takes to onset and then how long it takes for it to resolve. So sinus tachycardia, think about it, right? If you're running on a treadmill, it's going to take some time to get your heart rate up. And then when you slow down, when you start walking on that treadmill, it's going to take some time for your heart rate to come back down. It doesn't happen with the snap of a finger. Now, if you see an EKG like this, and then all of a sudden, abruptly after this point, we all of a sudden go into a normal sinus rhythm where we're at a heart rate of about 70. We have clear P waves, T waves that are very discernible. If that happens abruptly, then that is more of an indication of SVT. So the main difference that I want you to remember when you're thinking about SVT versus sinus tach is that SVT in general is going to tend to be abrupt. Okay, so it's going to happen very quickly. Okay, so it's going to onset very quickly and then it's going to resolve very quickly. And usually you don't really know what caused it in a lot of situations. For sinus tachycardia, usually there's something that we're aware of that's causing the tachycardia. Maybe it's anxiety, maybe it's running or doing some kind of physical activity. And then it's going to take some time for that sinus tachycardia to resolve. So that's the big difference that I want to, just call your attention to when you're thinking, what's the difference between sinus tachycardia and SVT? So that's the biggest thing that I would remember. Remember also that sinus tachycardia definition, right? Sinus tachycardia, it's usually going to originate at the SA node. So we're not going to change our mechanisms per se of where signals are originating and where they're going, right? In sinus tachycardia, we have P waves, right? The SA node is going to send a signal to the AV node, right? We already know this, and then we're just going to go down our pathway. Okay, but we're just sending signals at a faster rate. So that's sinus tachycardia. Okay, now with SVT, the difference is there's a pathway, a re-entrant pathway that's generating these impulses. And that's kind of why the signal comes on so abruptly, because we're not going through sympathetic stimulation to gradually increase the heart rate. Instead, there's this new pathway that's just taking over, that's coming out very fast, that's causing this very high heart rate. So it's a re-entrant pathway. Now, the number one place that you'll see this re-entrant pathway is the AV node. So to kind of make this simple, basically this is going to be your AV NRT. So essentially in the AV NRT, in simple terms, and we don't have to go into great detail here, but if I made a major cross section of my AV node, okay, so let's just say this is my AV node. Okay, and then on one side of my AV node, I have a slow pathway. Okay, so we'll just put slow. And then on the other side of my AV node, I have a fast pathway. Okay, now I have a signal that comes in from the SA node, right? And so that signal can go down one of two ways. It can go down the slow pathway, okay, or that signal can go down a fast pathway. Okay, so the fast pathway typically will get down here before the slow pathway. However, in certain situations, what can happen is the slow pathway can actually beat the fast pathway down here. And then it can start to travel up. And what happens is as this comes up, it starts to generate this reentrant pathway where there's a constant signal that's being generated. That helps me remember what AV nodal reentrant tachycardia is. Reentrant tachycardia in the AV node. So the AV node is the area where this circuit essentially lives. And so that's going to be AVNRT. Okay, so that's going to be this guy right here. Now that's going to be the number one most common cause overall, but not far behind it is going to be accessory pathways. Okay, so you can also have a reentrant circuit through an accessory pathway. So when we say an accessory pathway, right, so here's my SA node, and my SA node, my signal from my SA node, it has to go through the AV node to get to the ventricles. Remember, the whole point of that is that there's a refractory period in the AV node that's going to help delay the signal before it goes to the ventricle, so I can get atrial systole that's going to occur in my diastole phase, and then I get ventricular systole in my systole phase, right? And so when the signal gets to the AV node, it's going to eventually go down to the ventricles, right? It's going to go through the bundle of His, and that's going to go through vesicular branches, Purkinje fibers, etc. If I had an accessory pathway, so let's say I had a pathway maybe over here, so a side pathway. Okay, so if I had a side pathway, I can generate a signal either over here or even from the SA node, and that can go down this accessory pathway, and there's going to be no refractory period here, right? The AV node, it's kind of like a stop sign here. It's a stop sign saying, hey, slow down. There's a refractory period here. We have to keep things balanced. But if I have an accessory pathway, this pathway might beat the signal coming from the SA node. You'll see what this looks like in a second, but essentially, to spoil it a little bit, you get this slurring upstroke here because this accessory pathway is essentially beating the AV node and getting to the ventricles. Now you can imagine if we just take away some of these arrows for a second, right? So what could happen potentially here is this accessory pathway can essentially act to take the signal from the AV node and actually create a circuit itself, and vice versa. You can actually have a signal going this way and coming back up through the AV node. Okay, so these are going to be the types of AVRT, so the atrioventricular reentrant tachycardias. Okay, and they're broken down into two categories, which basically depends on which direction these arrows are going. I'll talk about in a minute. There's going to be an orthodromic and an antidromic. Okay, and again, you don't need to go crazy into the details here. It just helps to have an idea of what's going on. But the whole thing that you can see with all of these different supraventricular tachycardias is that they're due to reentrant pathways. That's the important thing to remember. Now, there's also atrial tachycardias, which we already talked about, atrial fibrillation, atrial flutter. The big difference between the SVT variants of these is that, remember, with like atrial flutter, for example, you might have some F waves, right? And so you kind of can have an erratic baseline too with AFib, right? So AFib can look something like this. So you kind of have this erratic baseline. But with atrial tachycardias, usually the baseline is normal. Usually there's going to be discernible P waves. So another small difference. But again, here's what I really want you to remember. For this video, again, when we go to step 2, we're going to go into more detail on this. But what I really want you to know here is that SVT has 3 major categories. Okay, it has AVRT, which essentially is most commonly going to be your accessory pathway. Okay, so the AVRT is most commonly going to be associated with your accessory pathway, and the one that gets tested is going to be Wolff-Parkinson-White. And that can be an orthodromic or antidromic type. The AVNRT is the one that's most common, so that's what you have to know about this. This is number 1 most common, and essentially has to do with a reentrant circuit in the AV node. And then finally, we have atrial tachycardias, which don't really get tested as often for step 1, but just to, for completeness sake, I've included it here. Now, going back to SVT. Now, when SVT usually gets tested, it's going to look something like this. So you can see that we have a narrow complex tachycardia. So what is a narrow complex tachycardia? So in simple terms, we can see here that this QRS complex is essentially taking up about a box, maybe a box and a quarter. Okay, so this QRS complex would certainly be in the category of narrow. Now, if it took up more than 3 boxes, okay, so if it was a wider QRS complex, so if it was something like this, right, that would be more of a wide QRS. That would be a different type of tachycardia, especially on board exams. So if you see narrow complex, you're thinking things like SVT, which it could be one of these 3 variants. It could be atrial flutter, atrial fibrillation, and we already kind of talked about how to differentiate those. One big thing is, SVT is going to have regular RR intervals, which is going to differentiate it from AFib. You're not going to see the flutter waves like we talked about with atrial flutter. The heart rate usually tends to be greater than 150, but like I said, this isn't a hard and fast rule, so it doesn't necessarily differentiate it from sinus tachycardia. If it's abrupt onset, no major precipitating cause, it tends to be more likely SVT. And again, this is typically going to be in younger patients. They don't necessarily have to have a cardiac history like some of these other arrhythmias. And like we said, abrupt onset. The classic symptoms for most arrhythmias are here. None of this is necessarily pathognomonic. Any board question you get on arrhythmias, usually they'll have shortness of breath, palpitations, especially if it's tachycardia. And then the other thing I put here is the P waves can be buried within the QRS complex. So when you get to higher heart rates, you can't really see the P waves very well. Okay, so don't say, oh, I don't have P waves, this must be atrial fibrillation. No, right? Because that's not the case, because you have regular RR intervals, right? That's something to just keep in mind when you're looking at this. Okay, so what would you do to treat this? Now, step one isn't, huge on the management, but there are a couple things in the management that I think you should just be a little bit familiar with. So when you're talking about SVT, the first thing that's usually done if the patient is stable. Now, stable, we're talking about the patient doesn't have hypotension, they're not unconscious, they're not confused, right? Maybe they just have a little bit of shortness of breath. Maybe they have a heart rate of 150, right? So the patient's stable overall. What you can do is you can try vagal maneuvers. And this comes up because, again, step one is about mechanism. So if I do vagal maneuvers, let's talk about the carotid sinus massage. This is probably the highest yield one in this category. So remember the carotid sinus, right? So the carotid sinus, we talked about that being an area where we're going to have baroreceptors at the carotid sinus. And those baroreceptors are going to send signals back up through cranial nerve 9, right? So the glossopharyngeal nerve is the afferent portion of this. And we already talked about this in a previous video. And this is going to go up to the distal brainstem, and we're going to have a signal going to the nucleus tractus solitarius. And that's going to send an efferent signal out. Now, if I put pressure on the baroreceptor, what does my body thinks happening? Right? If I put pressure on the baroreceptor, my body thinks that there's a higher pressure there. Okay? So my body thinks that because I'm putting pressure on the baroreceptor, my blood pressure is higher. Even though it might not necessarily be higher, it's because I'm putting pressure there. My body thinks that the blood pressure is higher. So my body is going to react from that carotid sinus pressure by doing what? My body is going to react by decreasing the heart rate. How does it do that? It does that by increasing vagal tone. Okay, so parasympathetics, right? So the parasympathetics are going to be responsible for bringing the heart rate down, specifically the vagus nerve, cranial nerve 10. Cranial nerve 10 is going to be responsible for increasing the vagal tone, bringing the heart rate down. And this is something, like I said, we've kind of talked about this. If you're not familiar with this, I would go back and watch some of those previous videos. But that's the general concept here, okay? So that's why the carotid sinus massage is used for this, because again, in SVT, we usually have some reentrant pathway. And that reentrant pathway is most commonly going to be in the AV node. If I increase my vagal tone, right, and decrease my heart rate, this is going to essentially act, the vagus nerve will essentially act as an AV blocking agent, right? It's going to increase my parasympathetics, and it's going to help me block this signal here in the AV node and at least increase the refractory period of it to help break this cycle. So that's why vagal maneuvers are used. Okay, so this is usually going to be kind of your first line. So if you ever see somebody in the hospital while you're on your rotations and there's a rapid response called and they have SVT and they're stable, usually the first thing you'll see the resident or the physician, whoever is there, you'll usually see them start to do vagal maneuvers initially, okay? Because they're trying to see if that can potentially resolve this SVT. Now, if that doesn't work, then they will go to adenosine. Okay, and again, it's all about mechanisms of action here. So again, remember what adenosine does. Adenosine has effects on inhibiting the L-type calcium channels. And remember, these L-type calcium channels, if you've been following the video series, we probably have talked about these in 3 or 4 different videos, but these channels are essentially used in the pacemaker cell. What's the big, pacemaker cells you're thinking about? You're thinking about the cells in the AV node, right? The cells in the AV node, you're going to inhibit their L-type calcium channels, and by doing that, again, you're going to increase your refractory period. Now, the other thing that adenosine does is it also is going to increase your potassium conductance. Okay, and again, we talked about all of this when we talked about the antiarrhythmics, but increasing potassium conductance in the AV node is also going to increase your refractory period. So adenosine does a really good job of targeting the AV node, increasing the refractory period of the AV node. And again, this is the same thing. You're trying to temporarily block your signals through the AV node. So you're trying to block this reentrant circuit, and essentially you're trying to get like a reset of this. So when you give adenosine, again, big difference between SVT and sinus tachycardia, you're trying to reset everything. And so when you give adenosine, it's very abrupt, right? So you can see a very abrupt change. They might go from immediately being an SVT, and then the heart rate starts to plummet down into the, the 110s or the 80s right away. And so that's what adenosine is doing. Just one kind of thing to remember, if you ever are in a situation where you're giving adenosine, you always kind of want to tell the patient, hey, you're going to feel like you're skydiving or free falling, or so. It's a very uncomfortable feeling. Patient might have some chest discomfort, they might have some flushing. Those are all common side effects with adenosine. But the biggest side effect that you should know for a board exam about adenosine is that it can block the AV node. Okay, because that's what it does, right? That's why we want to use it, because we want to block the AV node. The problem with this is, again, if we over-treat, we can actually start a third-degree AV block. We can actually really block this thing and get complete disassociation between the atria and the ventricles. Okay, but that's for the AV blocking lecture, but just kind of keep that in mind. It's really good. If you know the mechanism of action, you can put it all together. You can say this is when I would use to treat it, this is when I would not use it, right? The other thing on here is calcium channel blockers and beta blockers. Now, calcium channel blockers and beta blockers, we've talked about many times. It's the same concept, right? Beta blockers, I'm going to decrease my CAMP. I'm going to decrease my intracellular calcium in these pacemaker cells, but that will also inhibit my phase 0 and phase 4 depolarizations. Calcium channel blockers, same concept, right? I'm going to inhibit the L-type calcium channels. Remember, my pacemaker potential, what does it look like? It looks something like this, right? And so if I start to inhibit this phase 4 and phase 0, I might get something that looks more like this, right? So it's going to take longer for that depolarization to happen. That's what I want. I want to slow things down. I want to extend my refractory period and decrease my slope of my action potential. Okay, so that's what these two medications will do. Again, targeting the AV node, because that's where the majority of these reentrant tachycardias, that's where they have to go through. Either they're only in the AV node, like an AV NRT, or they're going through an accessory pathway that traverses the AV node in AVRT. Okay, so these are some things to keep in mind. Now, if a patient's unstable, there is different management. Again, I'm not going to go into too much detail on this for step 1, but immediately, typically, we can do cardioversion in an unstable patient. And again, this is a patient that's hypotensive, for example, right? They're in shock. This would be an example of when you would pick electrocardioversion, and then in the long term, you can do a catheter ablation of this pathway. And that would be more definitive treatment.